Welcome everybody to Preparing for the Sweeps. I'm Lisa Pouncey, and I'm the Senior Director of Product Management for Babel Health. I've been involved with data management for 30 years, and in the healthcare industry for the last 12. I have a passion for error correction, and over my years of tenure, I've been responsible for millions of encounters and the error correction for those, and just about every type of government program out there. And I was offered a position at Babel Health to help bring our tool up in the risk adjustment submission platform that it's in. We do have a great deal of functionality that we provide in encounter error correction, and because it's such a passion, I was really excited about coming on board and working with Babel Health. But we're excited to be here today to help target some of those questions that you have. And we'd be a little remiss in talking about error correction and the sweeps and the push for sweeps without starting with the major question, how do we get there? How did we get to the place where we are right now? And so we're going to spend a little bit of time looking at the root cause for some of the errors that you guys are seeing in your system today. How do you update the end game? How do you change that from continuing to propagate? What are some of the top processing mistakes that contribute to lost revenue? And then we're going to really spend the bulk of our time looking at and talking about the error correction process and how to prioritize your error corrections as we come up on the sweeps. So with that, let's just jump right on in. So to address the issue of systemic errors within a plan, we have to start by understanding how those errors occur. And the key that I have found that defines this is that there's a gap at each of the plans, and the gap can be defined as what your claims processing team and system defines as a clean claim versus what your encounter reporting group and the government defines as a clean claim. That disparity creates a gap. So the players, again, your claims processing teams, your systems that these data come into, your claims data gets loaded in and it goes through a validation process and it's approved for payment. And again, the focus of the claims processing team is to get the payer paid, the provider paid. The encountering reporting group, again, their focus is to get the data submitted to the government, and they're working on technology that's not fully understood. They're a little bit new to the claims processing group. They haven't been around for as many years, and the technology to support them isn't really as robust and well established as claims processing. So those are our players. What we see here is the gap, again, is reflected by the claims system and the processes that support those that defines what a clean claim is versus the reporting mechanism. And because there is this gap, there's a payment of claims that are being accepted into the system that are not clean enough to get submitted to the government. This is all not news to you. You're all on this call because you understand this, but there's a broad level of understanding that doesn't exist today in terms of how those errors really translate into monies and revenue impacts for your plan. And so we're going to talk a little bit about that. But the question is just how much and what does this represent? So I call the data that is not clean enough to get submitted to your government agency or those encounters that have already gone and been rejected from the agency. I call that your error pool. Those are your pool of claims that you're targeting for cleanup for the sweeps coming up this September. And that error pool can correlate to big dollars. In the example that we have on the screen, if you have 30,000 members and you've got a collective 10% of your encounters are in this error pool process, that can financially calculate out to be some big money for your organization. And the calculations that we've used to come up with the 5.9 million are based on some averages done by Milliman and some of the known statistics about HCCs in the industry. We have seen with some of the folks that we've dealt with specifically that when they begin to correct, that there's been some case studies done, and an average of $5 million+ that have come back through the process as they work towards cleaning, increasing their air pool success. Gets, excuse me, let me say that again. As they increase the success in the submissions to CMS and their air pool reduces, they've seen great financial results. And so the focus is on how do we target that. So back to the end game and what's going on. I mean, at a very high level, part of the challenge is when you have an established group like your claims team, is that they get in the pattern of, well, this is the way we've always done it. This is the same place, same thing. It costs a lot of money to change your technology that supports your claims processing. And it's really hard to motivate change to shore up some of that gap that exists. And so the successful response is to establish a reason to change, which means you've got to do a little bit of business case. Work with your actuarial teams, or if you actually have a technology that helps provide you with some statistics, use that to tie back the dollars and cents that are being lost through the errors that are not getting submitted into CMS and are not reflected in HCCs that represent additional revenue back to your organization. Helping to establish the reason to change is much more effective than bargaining that it's an error and it needs to be corrected. That is very difficult to come up against the same place, same thing syndrome. In terms of a business case, generally you want to show what is in an error state and what it financially is costing your system. And then there's another target of the end game that you have to go after, and that is this idea that there's going to be provider backlash if you start sending the claims back to them to repair before you pay them. And the truth is you have to manage that fear because there's nothing to lose but net loss. I mean, really seriously, these providers that are providing bad data to you on a regular basis generally know that they're doing that because there are lots of other plans that they are servicing memberships for who are coming back and saying, please resubmit this encounter to us. And many times the providers themselves aren't aware that the third-party vendor they're using to generate their claims data are not doing what they should be. So working with your provider network to target some of those specific providers that are historically giving you bad data, working on a 3-month strategy and setting up some quality incentives for them goes a long way towards helping to prevent this data and the data errors and the push that you have to go through each time you hit a sweeps period to get the data into CMS. So those are just a couple of suggestions. Again, you have to work within the capabilities of your technology and your actuarial team, your financial group, to help get those dollars and cents crunched out so that you can help report that exposure back to your organization and work through getting some change in. Okay, so let's move on to enough about the systemic issues and the gap that exists out there, and let's talk about error correction and where we are with that today. So the question I want you to think about as we go through this, or before we start this discussion, is it more important to correct a $20,000 claim or a $200 claim? And so the actual correct answer is it depends. And I know that's an odd answer for this, but the truth is your $200 claim can be extremely important in that it could be the first claim that identifies a chronic condition from the member. It could represent that office visit where the doctor says you have COPD or you have diabetes, and those are very important claims to capture and then make sure they get into the system. And you may be asking yourself, why is that important? The risk reimbursement process is based on the plan being able to deliver clean claims to CMS to establish the chronic conditions of their membership. So backing it up a little bit about the financial process, you have your per member per month fees that you get paid from CMS for managing your membership. But CMS says, hey, you know what, if you can get your data into us and establish that your membership has chronic conditions, then we will augment your finances by giving you risk money to help cover the cost for those members that we know cost you more to maintain. And so the key here is getting your clean data in to help show that that financial exposure is something that your plan is taking on, getting those monies back. So every claim at that point in time that goes into the system is evaluated for whether it is risk eligible and whether or not it establishes that your member has chronic condition. And so if you're not getting your data into the government, then they don't know that your members have COPD or have some other challenging ailments that you're supporting them in, and you don't get the monies back for those. So it's really important that you understand that every claim counts at this point. So we have to now begin to rethink how do we do error correction? A number of plans, out of lack of knowledge or approach for cleaning up data, have often gone by, well, let's just get the big dollar claims in because, of course, they're going to represent the most illness. And that may or may not be true. If I have a $150,000 open heart surgery claim, it may be that the established chronic condition, it was well established in the last 6 to 12 months. So it may not be as important as that single claim that indicates that in addition to the chronic condition, now the individual has diabetes or some other ailment. So it's important to acknowledge all encounters for the chronic condition they may represent, okay? Now, it's easy to quantify the error pool to target those that are going to have the most financial impact when you have the right tools to support you and do that. So we're going to take a look at what those are. And then one other method that we have to rethink is up until late the getting one encounter in with the chronic condition has been a sufficient reporting within each sweep, because that establishes that your member has the chronic condition. However, in 2020, they're going to be adding some additional calculations, and they're going to be counting the number of episodes that are directly related to the chronic condition and adding some additional reimbursement to the plan if there are frequent episodes that have to be financially managed through the plan or the organization. So that is now changing. There's a new direction that we're going in the way that they are going to be calculating some of that risk reimbursement. And I think that that's a big step in the right direction, but it also means every encounter is going to count. So it's rethinking the way you do error correction. So some of you have a third-party vendor, and those vendors will tell you what's in an error state, and they may help you know what you have that's out there that needs to be corrected, or what has come back that is sitting in a rejected state. But that's it. They don't necessarily tell you how to go about prioritizing what's in that pool for the error correction. So we're going to talk about that prioritization a little bit. So out on the screen, you can see CMS.gov. They publish a CPT HCPCS codes list of the procedure codes that they use to qualify claims for risk eligibility. Now, if you haven't got this list, you should go out to the link, and when you get a copy of the presentation, you'll be able to go out there. If you don't get this, the link is actually cms.gov. It's under the Medicare health plans. You'll get the link, the HTML link to get to this. But anyhow, downloading that current list of CPT codes and then looking at your encounters that are sitting in an error state, if you are able to extract those out, grab the procedure codes and do a comparison, any encounter that is got a CPT code that's on that list is one that you should target correcting first. Now, what if you don't have the mechanism or the capability of getting that information out of your claim system or out of your encounter system to compare to this? Then there's a quick way. I'm jumping ahead here. There's a quick way for you to narrow down the list, and I'll go to that in a minute. But what you're seeing here on the screen right now is just basically what is in this list. It's not a very, very advanced. It's just simply lists the CPT code. It shows your short description, and it gives you a yes or no. And so this is how you'll know you begin to qualify those encounters for risk eligibility. Now, if you don't have the ability, like I said, to get that data out of your encounter tracking system and compare it to this list, then here's a couple of rules of thumb. So, and some of you may or may not be surprised to understand this, but home health, skilled nursing, inpatient rehab, and hospice claims are not risk eligible. They're not. They are paid for through special payment processing, and they are not included in the risk calculations. So even though you may find you have a lot of skilled nursing and home health claims that are sitting in an error state, take them and put them aside until after sweeps. Let's target the ones that are going to help provide you with the financial reimbursement that you need to sustain your plan. I'm not saying don't correct them, I'm just saying set them aside. If it's a transportation claim, set it aside. Your laboratory diagnostic imaging encounters, again, they help determine the chronic conditions, but they themselves don't count when it comes to a claim that is used for qualifying a chronic condition. the government or CMS says this has to be, those diagnostic tests have to be reviewed by a doctor or a qualified medical professional, and that qualification and that office visit that provides that diagnosis back to the member, that activity qualifies the encounter and the actual chronic condition for risk reimbursement. So all of these encounters, though they may be problematic and they may be sitting out in your air pool to correct, take them and set them aside and work everything else, because everything else that's out there aside from these has a potential for impacting your risk. So now that we've kind of taken a different approach to how do I begin getting my hands around what I have to work for sweeps, we're going to separate those into two categories: what we call the some bucks or some dollar reimbursement, and the no dollar reimbursement, the skilled nursing, home health, and whatnot. Put those aside and target the ones that have a high probability of having some risk impact. And now let's drill those down and take a look at the ones that could actually give you more financial reimbursement. Now, you've heard me talk about, or just quickly mention, what they call an HCC. That is a hierarchical condition category list, and it's the list of chronic conditions that CMS has defined are risk reimbursable. So now we have two things. The claim has to have the right procedure code on it to qualify it for risk, and then the diagnosis code on that claim needs to fall into one of these categories in order for there to be monies associated with risk reimbursement. And so if you don't have a technology that helps you prioritize your air pool correction, or you don't have an actuarial team that's available to say, hey, clean this stuff up first, then the best thing for you to do is to either get your hands on the comprehensive HCC list and start looking at how you can integrate that into your technology, or you can begin to just commit to memory some of the diagnosis code prefixes that represent the more common HCCs that are out there. So what I've done over here at the list is anything that starts with a B, B20, B97, or if the diagnosis code starts with a C, a D, an E, and F, these are ones that you can teach your encounter cleanup crew to look at and recognize and target the correction on those first if you can. If you can produce a list by diagnosis code and start looking at those chronic conditions are easy to spot just by looking at the first character of the diagnosis code. And now what you're able to do is, just through visually inspecting the CPT codes or excluding some of the non-eligible encounters as a category and looking at diagnosis codes, you can begin the process of just targeting your cleanup to get the biggest financial impact as you approach your sweeps. Again, these are techniques that are not as foolproof as being able to incorporate the technology to actually incorporate the crosswalk for the HCC crosswalks that they have, or integrate your CPT code list. But a lot of folks don't have that available to them and are relying upon good old-fashioned muscle work to figure out how to get their data cleaned up for sweeps. And these techniques will help get you there a little bit faster, or at least get some of the potential encounters cleaned up and in for submission before the ones that have less impact to your company financially. Okay, so let's talk about the 4 processing mistakes that are high and causing lost revenue. So this list has been pulled in based on sourced from the CD, which is the Common Electronic Data Interchange, and they are the trackers of all your 277999 rejections, and they produce a culmination of those for January 2019. They published this list. So let's look at it. The number 1 and number 3, respectively, top errors, and reported back in January 2019 was having an incorrect procedure code and or an incorrect modifier, that they were being used out of the effective date. So what does that mean? What that means is, if you don't know who in your organization is responsible for maintaining the code sets in your claims processing system, you need to find out who that is and make sure that they are aware when those codes are published, and make sure that you get them integrated into your system. That will only help with ensuring that you reject or not pay claims that have invalid procedure codes for the dates of service, and it will clean up your or reduce the number of encounters that you have that are in an error state. The second one is not loading your MMR into the claim system. So the number 2 error is submission of bad member data, not having the correct MBI HICN assignment, having a mismatched coverage start and end dates, or bad beneficiary dates of birth. All of those are available in the MMR, and if you are able to integrate your MMR into your claims processing so that you are confirming eligibility information before you pay your encounter, then you'll be able to knock out the number 2 ranked error that's out there today. Number 3 is incorrect or missing billing provider NPI or EIN number. Those represent 4, 5, and 7 in the top 10. And if you can, my suggestion is to integrate looking up this information in the MPES database. That helps with establishing whether the MPI is a valid MPI, or even if the provider is a approved provider to provide services for CMS, or if they're on the naughty list. It tells you if they're on the naughty list. So if you can integrate the MPES in as a lookup process for your billing provider data, that would help eliminate number 4, 5, and 7 on the number 3 processing list. And then number 4 is inappropriately dated service date. So where you have pay date that's before the first date of service, or you have start and end dates that exceed the start date is greater than your end date. Those types of errors within the actual encounter themselves represent number 6 and 8 in the top 10. So if you can target those particular errors systemically in your system, then you will address the top 4 that are out there that prevent encounters getting into CMS. And a lot of times rejections that come back are interpreted in the systems that we have that help us maintain our encounters, and sometimes they translate into easy English and sometimes they don't. But if they don't, and you need help figuring out what it is, there is actually a source offered by CD, and it again is the www.ngscd.com. They have a 277CA edit lookup tool where you can provide the actual error that you're receiving in your reject, and they will provide an explanation back when you do the lookup on that. So that is a free tool that's out there in the event that you don't have a system that does a real world translation for you. Another resource that is out there is a spreadsheet that has the 277 rejections and 999 rejections defined for each of the components in an 837. They are divided by professional and institutional and DME, so you can look those up and get explanation for what those reject codes are from a 277 level. Again, if you when you get the presentation, they'll have the link. If you click here, it'll take you directly to the link that you can download, and it'll provide you with more information. But getting those spreadsheets, having them handy, getting them available to your team to help them understand what am I seeing in terms of what's getting rejected back from CMS. The first step to cleaning up the problem is to understand what the problem is, and those are tools that help you understand what those errors are. And then finally, there is one other resource that I didn't mention before, and that resource is let me go back here. Sorry, folks. It's the ED submission processing guide. It has all of the MAO2 errors that come back in an MAO2 response that defines what those are, so that if you get an MAO2 rejection and you don't know why you're getting it or what to do to correct it, you can look in this guide here. It's a CSSD operations, and it will help explain to you what the error is, and then once you know what it is, then you can work through correcting it. In general, the biggest key is to target your work towards cleanup for those encounters that are going to have the greatest financial impact for sweeps by becoming familiar with the CPT code risk qualification list, and by getting familiar with the more common HCC diagnosis codes that are out there, so you can target your work effort for cleanup. And then, of course, understanding the errors, and so you can work towards getting them corrected, and also address the long-term solutions within the organization by closing that gap between your claims processing group and your encounter reporting group. Okay, so we are through part 2 of the webinar. Excuse me, we're through part 1. We've got part 2 of the webinar coming up on Thursday. If you have some specific examples of problems that you're having a hard time working through, I would like to invite you to send them to me, de-identify them and send them to me, and we can incorporate them into our presentation in an anonymous way for everybody to review on Thursday, and see if we can't provide you with some specific help on how to actually address some of those challenging items that you have. And if you want to, then you can also, with this copy of this presentation, you'll be able to register for part 2 of this 2-part series. And I think that's it.
Okay. Well, we have a couple questions here. Our first one is, what changes do you see coming for the 2020 risk year?
That's a good question. So again, I touched on it just briefly in the presentation. in 2020, they're going to be using the HCC counting method, which is going to count the number of episodes that your members are having for chronic conditions, and they will be adding additional percentage points on risk reimbursement for those members who have chronic conditions. Just in 2019, we saw CMS add some additional HCCs that were not normally included in the HCC list, which is some additional ones that have to do with drug and alcohol abuse, and also with some chronic psychological issues that are out there that are being included into the risk HCC list. But we are moving more towards not just getting one encounter in, but multiple encounters. Every HCC in will count towards the financial reimbursement back to the plan. So that makes them more important to get corrected. Next question.
Okay, our next question. Can I submit chart review encounters to report diagnosis codes if I can't get a claim reprocessed to correct in time for the suites?
Yes, as a matter of fact, a lot of folks are not aware that there is a timely filing rule that says if you can't get an encounter cleaned within the timely filing, you are allotted the ability to send in an unlinked chart. So if I have an encounter that I know has got a high, it's got an important HCC on it, but it's one that I can't clean up because it's either too old or the provider is somebody that you have to handle with a kit glove, you can have a chart reviewer review the chart and provide the diagnosis code via chart, and you can send it in as an unlinked chart review, even though CMS expects you to clean up the encounters. If it's past the timely filing, you can send it in. Permissible. Next question.
Okay. Well, that appears to be the end of our questions for today. With that in mind, I'd like to thank you, Lisa, for a very informative webinar today, and I'd like to thank all the attendees for taking time out of their day to join us. Just a reminder that part 2 of the webinar series is on Thursday, so be sure to register for that. Thank you and have a good day.